Okay, Allison, we're set.
Yep. All right. Hello, everybody. Marinas, as people come, just please keep an eye on the waiting room and let people trickle in.
Yes.
So for those of you who don't know me, I'm Allison Agu. I'm an associate professor of adult and peds ID here, and I run the pediatric program, pediatric HIV program, as well as the ACE clinic on the adult side. Today, I wear my hat as the PI of the Johns Hopkins Wiki Partnership for Excellence in HIV Care across Central Maryland. And for those of you who don't know what that is, it's really a group of programs with the goal of achieving a more coordinated response to HIV care by establishing mutually beneficial relationships to increase the quality of care for women, infant, children, and youth, WICI, as a community. And we really want to build upon our existing structures and systems to create a dedicated network of providers, comprehensive providers, to coordinate across multidisciplinary systems of care. So we created this web series called the Part D Network Toolkit virtual series late last year to engage and amplify all of our voices. So on the next slide, let's go ahead and put that through. Next slide. You'll see some of what we have done. We've done motivational interviewing, highlighting Megan Toller and our group in the psych department. Today we have Rapid Start by Joyce Jones and Kaye Park, who I'll introduce shortly. And then you'll see several of the talks that we have upcoming. And the idea is to to take the expertise that we have here, not just at Hopkins, but with our partners, and really expand to all of us to improve how we engage with the WICI populations. All right. With no further ado, I'd like to introduce our speakers for today. It's my extreme pleasure to introduce Joyce Jones. Joyce is an assistant professor in the Department of Medicine at Johns Hopkins School of Medicine and associate medical director of our John G. Bartlett practice, our outpatient ambulatory practice here. Joyce does all things. She directs our Ryan White program. She also is at head of our PrEP program here. But because she does lots of other things too, she has an NIH-funded grant to really look at how we provide care and improve outreach for patients who under the end of the HIV epidemic, using home-based testing, linkage to care, PrEP, and HIV treatment. Before this, because she does everything, she was a medical director in the Baltimore City Health Department and previously at Chase Brexon. She's one of my most trusted colleagues, and it's really a pleasure to have her here today. But highlighting multidisciplinary and how we all come together, I'd like to also introduce Kaye Park. And it's my pleasure to say Kaye started with me as a research assistant over in the PEDS HIV program and has gone on to gain alphabet soup letters after her at MSN, MPH, RN, ACRN, formerly a nurse in the Bartlett Clinic, actually in the Polk service, and now a nurse in the Bartlett program and the Rapid Start program. With no further ado, please welcome Joyce and Kaye.
Thank you so much for that lovely introduction, Allison, and for inviting Kaye and me to give you this talk about rapid HIV treatment initiation. So I'm going to share my screen. Okay, did that work? Yes,
Yes,
okay.
yes. It worked, yes.
Wonderful. So, thanks again for the introduction, and I'm going to go ahead and get started. Let's see, is this working? Are you seeing my presentation?
We are.
Okay. Okay, I'm so sorry. I thought that I had it down, but I don't.
On the bottom left-hand side of the screen, it should pop up the options to change slides, but it looks like the slides just left as well.
Yeah, because I was trying to do my presentation mode, but oh, here we go. Let's try again.
You see your slides.
Okay, great.
There we go.
Okay, perfect. So, all right. I apologize. This is working the way I thought it was working. Okay. All right. Thank you again for the introduction. I have no disclosures, and the funding for the rapid HIV treatment initiation work I've been doing is through the Centers for AIDS Research at Johns Hopkins. So a lot of appreciation to the Johns Hopkins CFAR, who has been very supportive of this work and of me as an investigator. So my objectives in this talk are to review the evidence that supports rapid HIV treatment initiation and to discuss barriers and approaches to implementing rapid HIV treatment initiation. So I'm going to be giving the bulk of this talk, but Kaye is here and she is a really, really essential part of the work that we do. So I definitely want to leave time for her to provide her insights and to answer any questions. So I'm going to start with a case. So this is a patient who is an actual patient who is 25, and he presented to the emergency department complaining of 7 days of fever, abdominal pain, nausea, vomiting, and diarrhea. And very importantly, the emergency room actually asked him about HIV risk factors and did order an HIV test, which I have seen scenarios in which that does not happen. But they did that very important questioning and ordered the appropriate lab. His HIV risk factor was condomless anal sex with multiple partners and intravenous crystal methamphetamine use. So he stayed overnight. They gave him some IV fluids. They did some other lab work that looked okay. He felt better. And then prior to getting the test result, he was discharged to home. Later on that day, the screening test, the antigen antibody screening test came back positive. Here at Hopkins, if there's a positive or an indeterminate test, it reflexes to a confirmatory test. That confirmatory test was declared indeterminate. And then when we have that, again, fortunately at our lab, there was a reflex viral load that was done, and the viral load came back at greater than 7 million. So then the HIV testing team, again, lots of things to be thankful for here. We have great leadership in the ED that is aware of the importance of having HIV testing and linkage activities in the emergency department. Their team reached out to the patient and made arrangements for the patient to come back the next day to get the result. We don't like to give results over the phone, he was asked to come back so that we could share the results with him. So I will come back to that case. And now I'm going to move on to the focus of our talk, which is rapid HIV treatment initiation. So what does that mean? And what it means is offering antiretroviral therapy the day of a new HIV diagnosis or as soon as possible after diagnosis. And so this is from one of the early publications on rapid HIV treatment initiation from San Francisco. So in San Francisco, they, in 2013, started a rapid protocol, and I'll talk a little bit more about that, where they wanted to offer to people who had new diagnosis, so diagnosis within the last 6 months, or acute HIV infection, or a low CD4 count, rapid treatment initiation. And so this, I think, really nicely highlights the things that we do and that historically we have done over the course of days to weeks or even months prior to prescribing antiretroviral therapy. So, typically in the past, the standard would be somebody would get their test and then they often had to come back to get the result. They would receive counseling and education, and then they would get linked with the clinic. At the clinic, they may or may not see a medical provider at that time. They would talk more about how they're handling the diagnosis, help them with insurance issues, look at some psychosocial barriers to care and start to address those. Then they would have their visit with a provider. And at that time, they may or may not get started on medication and then, enter HIV continuity care. So the idea, again, behind Rapid Start is to compress the activities that we do prior to prescribing ART within a visit. And I'll talk a little bit more about that, but that's the idea behind Rapid Start. So we do all of those things that we've always done in a more compressed time frame, get labs, but don't wait for those lab results and go ahead and offer ART. So why do we want to do this? Why did the, folks in San Francisco, why did others feel like this would be a good thing to do? Well, when I was first training in HIV care, I was specifically told by a mentor, which was appropriate at the time, starting ART is not an emergency. At the time when I was training, the medication regimens were much more complex. There were, many more drug-drug interactions. There were a lot of side effect issues. If people weren't really adherent to these complex regimens, then they could easily develop resistance. And so that was happening with the medications themselves. Since that time, there also have been several very important studies that demonstrate the benefits of early ART initiation. So importantly, the START study, which demonstrated clear improvement in morbidity and mortality for people living with HIV who were started on ART sooner rather than later. For those of you who are newer to HIV care, we used to wait. So we would wait based on the CD4 count before offering antiretroviral medications. And then in this randomized study, it was shown that starting sooner had better health benefits to people living with HIV. And then also very important studies looking at transmission. So multiple studies among couples who one person has HIV, the other person was HIV negative, and demonstrating in couples, same gender loving couples, different opposite gender loving couples. Multiple studies have shown that when people living with HIV are on ART, get suppressed, stay suppressed, there is no chance of transmission to the HIV negative partner. So again, very compelling reasons in terms of an individual person's health, along with a public health perspective, along with less of a risk than it used to be in terms of starting ART, higher genetic barrier to resistance, much easier regimens that are much more potent. So again, and then, in terms of that compressed time frame, we can improve engagement for patients. So I've done, I don't know how many of these rapid starts, and it is very powerful to see a person who's newly diagnosed, hear more about what they know about that. What does that mean for them? How are they handling that? And then to be able to offer them treatment then. And then avoid unnecessary clinic visits until the time of ART initiation. Help overcome some of these financial and logistic barriers. When we ask people to come to us to clinic all of the time, that's a lot of sort of organization and time and money for people to come to us before we start them on ART. And then, we're telling them, I know that this diagnosis is significant, but we know these wonderful benefits. We have excellent treatment for you. We tell them about the individual benefits to their health, and we tell them about being able to avoid transmission to partners. And then at that same time, we're giving them the tools to do that. So the early studies on rapid HIV treatment initiation were 2 randomized controlled clinical trials, and then this sort of rapid cohort study in San Francisco. So I'm going to go through those 3 studies now. So the RAPID trial that was conducted in public health clinics in South Africa, in that protocol, people who were newly diagnosed with HIV were randomized either to standard of care or this RAPID protocol. So standard of care, it was these sort of multiple visits for lab work and counseling. And then at visit 6, they would get their antiretroviral medications dispensed. And with RAPID, again, that was compressed into visit 1. 377 patients enrolled, 190 were randomized to standard of care, and 187 to Rapid Start. And here are the results. So of the people who were randomized to Rapid Start, 97% had started ART by day 90 after diagnosis, compared to 72% in the standard group. And that difference was statistically significantly different. And then in terms of viral suppression, so by month 10, 64% in the RAPID group compared to 51% in the standard group achieved, and they define viral suppression as less than or equal to 400 copies per ml. So again, a relative risk of 1.26, so improved outcomes in the RAPID group. In the Haiti study, similarly, people who were, this was done in public health clinic, people who tested positive for HIV were randomized to either standard ART initiation or the same day initiation. So for people who were offered the standard initiation, it was day 21 when they started on ART compared to starting same day. There were multiple visits in those first 3 weeks, but they had already started ART at that same, or they were offered ART that same day of HIV diagnosis. And then the primary outcome in this study was a combined outcome of retention and care at 12 months with a viral load of less than 50 copies per ml. And in the same day compared to standard group, improvement in this combined outcome, 53% compared to 44% in the same day group. In their secondary outcomes of retention and care at 12 months with a viral load of less than 1,000, 61% in the same day group compared to 51% in the standard group. And then looking at retention and care regardless of viral load results, almost 80% in the same day group compared to 72% in the standard group. So evidence of improved viral suppression as well as retention and care in this Haiti study. When they did multivariate analysis and adjusted for baseline covariates, again, still showing that this combined outcome of retention and care with a viral load of less than 50 was improved in the same day group. Retention and care with a viral load of less than 1,000 also improved in the same day group, and evidence of a mortality benefit as well in the same day group compared to the standard group. There was a meta-analysis that included these studies along with other studies, randomized trials, looking at rapid HIV treatment initiation. In this meta-analysis, there was a trend toward a mortality benefit with Rapid Start. So possibly not enough studies and individuals included or follow-up to really say that mortality was improved, but there was a trend toward improvement in mortality outcomes. There was a statistically significant improvement in virologic suppression at 12 months. Uptake of ART also improved in the rapid arms of the study compared to standard of care, so both at 90 days and at 12 months. So, the randomized trials that have been done with Rapid Start have been done outside of the United States. And again, evidence of improvements in viral suppression, ART uptake, and in retention and care. Some evidence that it could also improve mortality outcomes. So in the United States, again, no randomized controlled clinical trials, but really the leaders in this have been group in San Francisco, UCSF. So in 2013, they started this rapid protocol, again, where people with acute or recent infection or CD4 count of less than 200 were offered rapid HIV treatment initiation. So that first slide that I showed you comparing standard of care to rapid, that came from this paper. And so this is in their San Francisco General Hospital HIV clinic. It was a clinic-based cohort. And they offered this rapid protocol to 39 individuals. So I already told you about what that looked like. So it was, offering the same day. And then they would start the ART. They would do the medical and psychosocial evaluation, get labs, partner services, all of that work. And then in 5 to 7 days, they would schedule patients to have their primary care follow-up visit where they would review the lab results. If they needed to change ART, then they would. And what they did is they compared that clinical cohort to a similar cohort. So this is the rapid cohort. Universal ART, they compared them to a cohort who were also seen in the clinic at the same time, around the same time, not offered the rapid protocol for various logistic issues. But it was at a time when, we were still saying people should start ART regardless of CD4 count. And then they also compared outcomes to a cohort or a group who started ART in a time when we were using CD4 guided ART initiation guidelines. So in this group, they found that of the 39 people who were offered rapid start, 35 started that same day in the clinic and 37 started within 24 hours. So high acceptability. And then when they compared them to the universal ART group, they found time to viral suppression was 1.8 months in the rapid group compared to 4.3 months in the universal ART group compared to 7.2 months in the CD4 guided era. So faster time to viral suppression, high acceptability, also importantly feasibility, which is a big piece of this in this small cohort study. They then this clinic then published their data from a larger group after more time had passed. So this was patients seen between 2013 and 2017 in their clinic who were offered this rapid start. So the Ward 86 is very similar to the clinic we have in Baltimore in the sense that it was started in the 1980s, similar to the Moore Clinic, serving a population who comes from testing sites around the city affiliated with an academic medical center. And so they looked at their data of people offered rapid start from 2013 to 2017, and there were 225 individuals. 97% started immediate ART. So again, really high acceptability. 51% of these individuals had active substance use disorder, 48% had mental health diagnoses, and 30.6% had unstable housing. So this is the percent of individuals with a viral load less than 200 over time. So of these 225 individuals who they followed, they had outcomes for through 3 years. At year 1, 96% had achieved a viral load of less than 200. And then at 3 years out, 92% of them, their last HIV viral load was less than 200. So this is, again, demonstrating this high acceptability. It's demonstrating feasibility among a population that has complicated psychosocial issues and good evidence of viral suppression that is sustained. So based on the success of this and other work, San Francisco expanded this citywide. So they have coordinated with the San Francisco Health Department so that everybody who's newly diagnosed with HIV, they want to link them to care within 5 days, and then at that first clinic visit to start ART. So to be eligible, they have a new or confirmed HIV diagnosis based on the CDC algorithm. Places do rapid testing. And in the case where there's been a rapid test or there's been a screening test, but no confirmatory test yet, if there's a high pretest probability of HIV, they go ahead and do rapid start, knowing that it might be a false positive, in which case they would switch maybe to PrEP or laboratory evidence of acute HIV infection. I'm not going to go into the details of this, but this is their sort of referral algorithm. So these are different testing sites. They have a really robust linkage to care team, and then they're getting linked to this initial rapid visit. It's not just at this one clinic. They have multiple clinics that are set up to do rapid start. Okay, so here's their citywide results. So this is looking at the outcome of a viral load less than 200 of the last test of these individuals within 12 months of diagnosis. So they looked at this data citywide for people newly diagnosed with HIV from 2013 to 2017. And when they look at all of the newly diagnosed patients over the span of these years, you can see that of the people who were newly diagnosed, who were given rapid ART, 91% of those individuals achieved this viral load of less than 200 as their last test. And of the non-rapid ART, 78%. So that was a relative risk of 1.17. So this is across the span of 2013 to 2017. You can see that, the outcomes improve. And then the best year was 2016, when 98% of the people who, 98% were given rapid achieved this viral load of less than 200 at their last test. And then just overall, so the number of new HIV diagnoses decreased from 2013 to 2017 in San Francisco from 399 to 207. The median time from diagnosis to ART initiation decreased from 28 days in 2013 to 1 day, which is pretty remarkable. And then viral suppression, the time to viral suppression also decreased from 146 days in 2013 to 76 days. So, there have been other studies in other settings, other clinics. Atlanta, I showed you San Francisco, one of their clinics, and their citywide program, New Orleans, San Diego, Miami, Chicago. And what these studies are showing, they're all sort of, observational cohort, highly acceptable, increased likelihood of viral suppression, decreased time to ART initiation, decreased time to viral suppression, sustained viral suppression, and sustained retention and care. But there are mixed results. So more studies have come out recently. There's the SLATE study that was conducted in South Africa and Kenya, where they had an algorithmic approach to antiretroviral rapid HIV treatment initiation for newly diagnosed patients. There was higher ART initiation at 1 month, but no impact on retention at 8 months in that study. In an observational study in France, people who were started on ART less than 9 days compared to people who were started over 90 days ART, there was a higher loss to follow-up at 1 year for the people started less than 9 days. And then in another, this was a large cohort study in public health clinics in South Africa, same day compared to greater than 1 day of ART initiation led to what was associated with a higher loss of follow-up in the patients who were started same day. So, importantly, I think what these studies demonstrate is that it's not just about, having that visit and then writing a prescription, right? Like, there are other things that we need to know about the context of these studies, including things like the social determinants of health of these individuals, and things like stigma, things like how complex is the healthcare system. You know, one of the things that we talk about with Rapid Start is how much are the longer term outcomes sort of in the purview of the Rapid Start realm, right? Like, we know, you know, you can do a Rapid Start, but then what is sort of the clinical care system that patient is then entering? And that, you know, sort of retention, how much are social determinants of health being addressed, those kinds of things will play an important part in these sort of sustained outcomes, these longer term outcomes. There's also evidence of health disparities. So in the San Francisco citywide study, different groups did get Rapid Start compared to other groups. So for example, Latinx individuals had higher rates of Rapid Start than other individuals. Transgender women had lower rates of Rapid Start. So those types of health disparities we need to really pay attention to, so we're not, you know, amplifying disparities by offering Rapid Start only to some and not to others. So, you know, again, in general, it's important to know the complexity of the healthcare system. So here, you know, we don't have universal healthcare. It's not a public health system. We have a lot of what we have to do has to do with navigating the complexity of the insurance type and where they have to go for labs, what we need to do to get people medications. Clearly, again, this demographic, socioeconomic context and social determinants of health are a very important piece of how we're offering Rapid Start and then these linkage and retention services. There was a really great editorial by Mbako from Columbia in New York City talking about health equity, and that, you know, rapid HIV treatment initiation shows, you know, clear improvement on health outcomes, but there needs to be an explicit conversation about health equity. So things like systemic racism, homophobia, transphobia, stigma, medical mistrust, those need to be explicitly addressed in our programs, and may have impacted some of these studies that had didn't have the positive outcomes that we've seen in other work. So, you know, based on the evidence of the benefits of rapid HIV treatment initiation, this has now become standard of care. So the WHO guidelines recommend Rapid Start for people newly diagnosed with HIV, the IAS USA guidelines, and then the most recent DHHS guidelines as well recommend Rapid Start. And it's part of our Ending the HIV Epidemic Plan. So the National Ending the HIV Epidemic Plan, the goal is to, within 5 years, reduce new HIV infections by 75% and by 90% over 10 years. You know, here's this: diagnose all people with HIV as early as possible, and to treat people with HIV rapidly and effectively to reach sustained viral suppression. Without intervention and despite progress, and we have other tools obviously to help us with this Ending the HIV Epidemic Plan. So when this plan was created, it was estimated that about 400,000 Americans would be newly diagnosed over the next 10 years, despite all of these tools we have for prevention. So how do we do this? How do we adapt it to complex health systems? What are the co-interventions that we need to offer? What support do we need to provide patients to accept ART link and remain engaged in care? And like, again, there's this huge feasibility question as well. So this, you know, sort of the beginning of Rapid Start was when I had an opportunity to get funding to develop a Rapid HIV Treatment Initiation and actually Rapid Restart program through CFAR funding in 2017. And then since that time, Kaye is, her position is a position I created leveraging Ryan White funding. So we're able to continue our Rapid Start program using Ryan White funding through a pilot that we started in 2017. And then I also got this CFAR grant for the Baltimore Rapid Start Coalition that builds on previous collaborations among the 4 largest HIV service providers in Baltimore City. So Chase Bruxton, University of Maryland Thrive Program, the BCHG Sexual Health Clinics, and the Johns Hopkins John G. Bartlett Specialty Practice. And among our 4 clinics, in 2017, 48% of the new HIV diagnoses were made at one of our 4 institutions. So, you know, part of the idea behind this was let's start doing this in our clinics. Let's collaborate on how we're doing it. And then, you know, just even within our institutions, we'll be able to capture a lot of these people who are newly diagnosed with HIV and offer rapid HIV treatment initiation. And so we have, we're focusing on 3 pillars of the ending the HIV epidemic, the rapid HIV treatment initiation. We're also looking at rapid PrEP and NPEP, and then connecting back with the health departments to bring surveillance, what people identify through surveillance into rapid HIV treatment and rapid HIV prevention activities. So what have we accomplished as a collaborative? We've identified barriers, facilitators, and interventions to improve Rapid Start, Rapid PrEP, and NPEP. We have all now developed and implemented and refined our Rapid Start programs in our clinics. So one of the clinics did not have a Rapid Start program. Different clinics were doing different things for people who were uninsured. So we were able to come together, learn from each other, and develop some guidelines for implementation here in Baltimore City. We've created some draft best practices for Rapid PrEP and NPEP. The Rapid PrEP one is pretty much ready to go. Very importantly, we worked with the City Health Department and the State Health Department on this piece of connecting people who are diagnosed with HIV in the city elsewhere to offer Rapid Start. That work was pretty robust before the COVID pandemic. And, you know, really, really important for this sort of linkage to care and, you know, refining those systems to make this available to people who are newly diagnosed with HIV. You know, in this work, when you do have a lot of different moving parts, having these discussions, developing these relationships, I think are really, really essential. It helps you create better protocols and better systems because you get input from all of the people who are involved in the process. You get to know each other and you get to trust each other. So, and then you have staff turnover. So I think that, you know, for these, especially these sort of citywide projects, making sure that you're tending to the work, tending to the relationships is very important, and creating that buy-in from all of the members who have an interest and a part to play. So here's just some self-report outcomes, and this is looking at 2018 to compare to 2019. So there was an increase among our clinics in the number of people who received rapid HIV treatment initiation. We also increased our PrEP numbers and then NPEP as well. Here's what we do at Bartlett. So this has changed with Kaye. So she's been just a wonderful member of the team. And so when people are newly diagnosed with HIV, very, very importantly are these linkage relationships. So, you know, we do have HIV testing within our clinic, but we get a lot of referrals from the ED inpatient unit, community collaborators, and then central scheduling. So some people self-refer as well. So what happens now is really, Kaye, who's our early intervention services nurse, she hears about all these new people who are coming to the clinic who may or may not be newly diagnosed with HIV. And then she conducts an intake, ideally same day. Sometimes it's like next business day. And then she's able to determine who are the people who are newly diagnosed, who are the people who have HIV but are not on treatment. And then simultaneously, she is connecting those patients with a clinic visit with a provider who can prescribe same day, next day. And then also she's activating like the social work case management piece of things. And then also if the patient has like a mental health or substance use disorder or issue, she's also starting that process. And then we have really wonderful navigators as well who are available and who will be able to help support the patient, when they first come into the clinic and then beyond. So barriers, weekend and after hours is a barrier, insurance type is a big barrier, and then staff availability is a barrier as well. Okay, so, there are challenges to this. It's a rapid, intensive response needed to unpredictably timed need that does not require hospitalization. Sometimes people are hospitalized. It's sometimes easier to do this stuff when they're inpatient, right? Because they're inpatient and we can get a lot more things in order. We have a rigid, inflexible healthcare system with limited availability to address these time-intensive, unscheduled events. Costs for medications for uninsured, underinsured, I think we've found some solutions to that we can talk about. I talked about insurance type. You have a lot of different people you need to coordinate. Patients are feeling an emotional toll of the HIV diagnosis, and then you're trying to do all of these other things, and the patient may need to be there for longer than you would like to get all those things done. We had initially provider and staff buy-in was a problem, but it's like anything, the more that you start doing the work and the more systems that you have in place to support the work, I mean, it's now become something that is just part of what we do. And people have seen, sort of the benefits by being a participant themselves. And then again, the easiest thing, I think the easiest thing that we do in HIV care is like write a prescription and order labs. I do rapid HIV treatment initiation. I just write a prescription and order labs. That's like super easy. The important work comes with all of the things I've been talking about. It's the complex context in which we provide care. And it's the complex issues that patients are facing. But these are also, real opportunities, right, to help support patients to get at a better place of wellness. Okay, so solutions, I think protocols are super helpful. So if, we have things sort of outlined in terms of what are the different things that need to happen, and then, who is doing what. So when we do our collaborative work, what happens at Chase versus what happens at the Thrive Clinic versus what happens at the sexual health clinics, it's different. And there are some things, as long as you know what are the things that should happen, and then you identify people who do those things, it will work. But you need to sort of personalize it to the workflow and the resources of your clinic. You do need some people who have flexibility. So Kaye, her job, this is her job. She's very, very busy. And so she's, getting calls. She doesn't necessarily know what her day will bring her, but don't worry, she's not sitting around, she's running around. We look at the schedule to see who's available. We have attending physicians who are wonderful in our clinic who were able to connect to these rapid starts. We have acute providers as well who are able to do rapid starts. We look for openings in the schedule. And then I see a lot of rapid starts. I have administrative and other responsibilities, but I am a default provider, and I am experienced enough that I feel like I can do it efficiently, and I really enjoy it as well. But you need to have that give in the system. One of the publications from Atlanta, they started a rapid start program in their clinic, but then they stopped it because the providers were feeling overly burdened. And, you need, again, to set up a system that's going to support all of the members of the team. We leverage our Ryan White funding for the medication piece. Other clinics we're not allowed to use samples, but other clinics get samples to provide the medications for people who are totally uninsured. But that's a big piece, is figuring out the coverage part. We also are very fortunate to have a wonderful, very knowledgeable on-site pharmacy where we can have people walk out of the door with medications. So different sites have had to figure out different kinds of things to be able to have people walk out of the door with meds. Other things, acceptance is better late than later, right? Like, you're trying for as soon as possible, but sometimes you can't do it, and that's okay. I think also, again, these sort of logistics of notification, having Kaye be available, and then making sure that we're connecting to all of the sites that might refer patients so they know about her has been important. Switching central scheduling so they schedule with her has been very helpful. And again, addressing these social determinants of health and health equity issues, really explicitly is important. So incorporating that into the intake, connecting patients with supportive services and interventions as needed, fostering shared decision-making. So, you don't want people to feel forced, right, to do something that they do not want or they do not feel comfortable with. But you also don't want to perpetuate health disparities. So making assumptions about what people can and cannot do based on their other psychosocial issues, you're doing, I think, that patient a disservice by not empowering them with some shared decision-making. And then incorporating health equity outcomes into program evaluations. In our guidelines, we have that explicitly laid out in terms of our programs, looking at health equity, and if there are disparities, looking more into that. Why might people from certain groups not be getting offered Rapid Start or not engaging in Rapid Start compared to other groups? So COVID-19 impact. There's been decreased HIV testing and outreach activities, DIS services, and so disease intervention services were suspended. These are the folks who link people to care, and we had limited in-person visits. So that's been addressed through some home testing expansion. We've continued to do in-person visits from the beginning. Like, we deemed people who have HIV not on ART, that's essential to come in. We have navigators who've expanded their services to include wellness checks, also talking about COVID-19 concerns, and then linking with people who are new and re-engaging in care. Telemedicine has been very helpful as well. I had a patient who, Kaye identified a patient who was having a really hard time with his diagnosis, didn't want to come into the clinic. We had a really great telemedicine visit, and then he came in the next day and started ART. And now we do have rapid HIV testing, and the DIS services have resumed. So this is the impact of Kaye. So from March of 2019 to September 2019, our evaluations for Rapid Start and Rapid Restart, we had 10 newly diagnosed patients and 6 previously diagnosed patients re-engaging in care. With Kaye coming on board, we have done evaluations for 21 new patients and 65 previously diagnosed and re-engaging in care. So she's been really, really a wonderful piece of this program. Okay, let's get back to this patient. So as you recall, he's 25. He had a week of fevers, abdominal pain, nausea, vomiting, and diarrhea. Had HIV risk factors of condomless anal sex with multiple partners, crystal methamphetamine use. His test was done, but didn't come back. He had to come back. He has evidence of acute HIV infection with a confirmatory indeterminate test and a viral load of greater than 7 million. So he came back, he got his diagnosis. I actually went and saw him there. And then we came to the clinic. We did all of the things. So from the time of him coming back to coming to clinic and doing all of the things, it was like 4.5 hours. So that's a long time. But he did it and he started. And since then he's done great. So adherent, I don't know if it's still 100%, but he's very adherent. He's working. He's relapsed into using drugs since this time. So by day 68, he was undetectable. 3 years later, he remains undetectable. He's currently not injecting drugs, no symptoms. He's engaged in care. This is his lab of greater than 7 million, right? And then he's stayed undetectable. This is the trajectory of the CD4 count. And beyond these numbers, you know, again, it's being available also for the patient, supporting him with the rest of his life and his health, and making the HIV, what I tell patients is we want to make the HIV, you know, it's an issue, it's not a non-issue, but we're not going to let it impact your health or your sex life or all the other things, you know, that you want to accomplish for yourself. So in summary, you know, rapid HIV treatment initiation, it's the standard of care for people newly diagnosed with HIV because of very positive HIV outcomes in a variety of settings. I think successful programs will address this rapid linkage from testing to treatment. We didn't talk a lot about that, but that's very important. These complex healthcare infrastructure and insurance barriers to care, the social determinants of health and health equity issues. Really, again, I think, you know, when it comes to disparate outcomes with Rapid Start, I think it has a lot to do with who are the patients that you're seeing, and then what are the barriers they face, and then how are we successfully mitigating those barriers? You know, and then there may be reticence, right? Like people are used to doing things the way they usually do. And so you have a multidisciplinary approach to developing your protocol, to training, to implementation, and to refinement of your procedures as you need to. New York State has, like, there are not a lot of guidelines. New York State has guidelines. They have a really nice toolkit. And the Getting to Zero San Francisco Rapid Resources, I'm happy to share the Baltimore City guidelines that we've developed as well. So that is my conclusion. I feel awful that I didn't give Kaye more time. There's only 6 minutes left. But that's my presentation.
Joyce, that was fantastic. I think it's really lovely to see how you synthesize a passion, because I know you and I had some discussions about, can we do this? Is it the right thing? Can youth do it? And to see it play out. And really, you know, there's so many kudos in the chat for both you and Kaye. So I want to highlight that. And I think it's important to say that what Kaye adds, not just the calling, et cetera, but she really has been the safety net for those people as you get them to move on. And some of them don't want to leave her either. So I think really amazing to do, and I think underscoring just how much you have been available when nobody else could do it. You've been that provider. So a really fantastic job. There are a few questions in the chat, so maybe we'll go there first and then we can open it up. So somebody, Lonnie asked, do these citywide results reflect a certain age range? Maybe you could start with that one.
Yeah, and you know, we need to, first of all, for the citywide data, we need to create the mechanism to share our data. So again, this has to do with these logistic issues, right? If we had universal healthcare and like a universal, EMR, like we could analyze this data so much easier. But it's, you know, our clinic has a lot of older patients. So I don't have the data in terms of the ages readily available, but it is typically, you know, not the young adults, but more kind of over 30, who are the people that we're seeing, or that we've seen.
Yeah. No, and I think that goes to some of the concerns that some populations may be challenging. But that being said, I think, you know, certainly we've seen all age groups. We've gotten a fair number in ACE and have done okay with so I think it's important to, like you said, offer, not create an additional disparity by not asking. The next question is, are there potential harms for Rapid Start on HIV negative individuals? And that's from Aubrey Alvarenga.
I think, you know, one of the early concerns had to do with if we're starting ART and people have resistance, like baseline resistance, the rates of resistance at the time of diagnosis is low. We've had a couple of patients that we've had to change. I'm not sure what negative impacts there would be on HIV negative individuals. I guess potentially if someone developed resistance and then transmitted that to an HIV negative individual, that might be a concern. But did you have, oh, I see, Aubrey, I see your picture.
Yeah, there's Aubrey.
Something specific you were worried about?
I was just asking because when I do rapid testing too, if there's been situations where people are with their preliminary results, and that's probably one of the first questions that they're wondering if they should start or wait.
Yeah, and I think, you know, what they do in San Francisco, and that's what we should do here, it's that pre-test probability. So if they, you know, we've had patients who have had this preliminary test, but like no risk factors. And I think for those patients, you can, you know, counsel, but those are people I would not necessarily start. People who have, you know, many risk factors and are at high, your pre-test probability that this is a true HIV positive, I would start them, but give them the caveat, and I've done this. Your confirmatory test may be negative, in which case we'll stop the medicine. And then if they are somebody who could benefit from PrEP, you know, then we can transition to PrEP if we need to.
Thank you.
Yeah.
Other questions in our last 2 minutes? All right, Joyce, I see you. Go ahead.
I don't know, Kay, I feel bad. You're like on the presentation, and do you want to maybe speak a little bit to, you know, this work?
Sure. So I was coming from the Polk Clinic, and it's very, very difficult on coming from a bedside nursing position to an outpatient position. You're not up to date on the most current information. So I actually didn't even know of Rapid Start when I came over. I was still under the condition of, like, you know, yes, universal ART for everyone, but also assessing socioeconomic and psychosocial factors before rapid starting. But then I read the studies, and I think it's probably one of the best things to, you know, prevent HIV infection in general. And I'm such a big proponent of it now. And one of the things is I think that Rapid Start is really, really great for you know, people, and, you know, making sure that they stay engaged in care. But I also, you know, working in this position for the last year, I feel like the most important thing is whenever they start ARTs is just that they get all the support and resources they need. I find a lot of people coming in here, and you know, they're so nervous. They don't know how much the medications are going to cost, how much care is going to cost. They haven't told their family yet. And so I think that looking at the success of patients, yes, it's important, you know, to get started on medications, but it's also really important to make sure that they have the support they need.
Hey, what has been your biggest challenge as the nurse to navigating all of this?
Mhm.
What would you say has been your biggest challenge?
Whew, that is hard to say. I think it's definitely, it's working with the patients and, you know, meeting them on probably what is their toughest day, you know, in their lives. So many of them are, when they come to their clinic, they're so scared, they're so emotional. And, you know, I'm also throwing a bunch of information at them, and they're, you know, I think that's probably the hardest emotionally for me and the patient. But what I found helpful is just being with the patient throughout their entire visit. So warm handoff to everyone, making sure that they get escorted from step by step, I think really helps them. And I think it makes them, you know, realize that someone's going to be there for them in the clinic. They're not doing this by themselves. You know, I've seen a lot of ACE patients, 18-year-olds being in the health, basically coming into the health system for the first time in their lives. And they have no idea what to expect. They have no idea how insurance works, how clinic visits work, so I think just patients knowing that they have resources in the clinic.
Thank you so much. This really was a pleasure and wonderful to see it sort of play out. We've hit the 1 o'clock hour, so I want to be mindful of that. Thank you for everybody who attended. You will get a follow-up to please evaluate what you saw, give us feedback if there are other things you want to hear. We do these monthly, and really it's not just providers. It really, the goal is for it to be multidisciplinary. We have really all specialties. We have the best, giving us the best of what they do. That's the goal, to bring us all together and to elevate us all. So thank you, thank you, thank you. Please be safe out there, and we'll see you next time. Oh, one last kudos to Marina Steraforte, who really helps behind the scenes to organize all of this. She never puts her camera on unless I make her, so I won't make her. Really,
Next time.
keeps us all, you know, gets everything out. You get evaluations from her, so kudos to Marina. Thank you, everybody. Please be safe.
Thank you, everybody.
Bye.